Good. Some of you guys look familiar to me. All right, hospice. So exciting topic, right? Asceracare Hospice. So we serve pretty much a fourth of the state, 35 counties. We go all the way out west to Lake Chamberlain, Miller, Huron, Lake Andes, go up to just smidge. We can't cross into Minnesota or Iowa. So provide services in a large variety of areas. Hospice can be provided anywhere a patient calls home, whether that be a nursing home, assisted living, a private home. We go to them. There's also inpatient settings for hospice. How many of you have heard of the Daughtery House, right? Ava House, Stanford Colleges. That is where a patient would go into one of their facilities, and hospice is provided there 24 hours, okay? Hospice services are covered by Medicare, Medicaid at 100%. Listen closely to a lot of things I say, because at the end we're going to have a quiz and prizes. So, covered at 100%. This is a free benefit to people that need services. A lot of people don't know that. How many things in this world do we get free? Not very many, right? Free benefit. Also, insurance companies. A lot of time insurance pays for hospice at 100%. Think about the people that we're servicing for hospice. They're very sick, right? They've been to the hospital a lot. They've been to the ER a lot. They've had cancer treatments, IV fluids, Med A, skilled therapies, all right? They've used a lot of their benefits already. They've paid for their co-pays, their out-of-pockets. So a lot of times by the time they're coming to hospice, all that's met, so insurance is paying at 100% as well too. If there's ever a patient that does not have insurance, we're not going to just send them away and say we can't help you, okay? We're going to sit and look and see what can they do, can they afford anything to pay for hospice services, and if they can't afford hospice, we're going to help them anyway. We're going to give them hospice for free, okay? So we're always going to help a patient no matter what. Hospice is per patient that their life expectancy is 6 months or less. Does not mean that they are going to pass away in 6 months. They could live for weeks, days, months, years. We've had patients on our services for years, okay? Now, it also doesn't mean that they're absolutely going to die. Sometimes patients come on our services and because of just extra TLC, sometimes because of med changes, and sometimes just because it's not their time to die, they come off our services, they graduate. We celebrate those moments, okay? Just because a patient comes off our services because they're doing good, doesn't mean that they can't ever come back on our services. It's not like you get to be on it once and you're kicked off and you can never come back on again. If they would graduate off, if they say they 6 months down the road they're not doing well, we reevaluate them, and if they meet criteria, they can come back on services. For a patient to come onto services, we have to have a hospice order from a doctor. That's very important. Just like any other treatment, there has to be a doctor's order. There also has to be that they are ready for comfort care, right? They have to forego wanting to do anything aggressive. So we aren't going to do any more treatments. We're not going to have chemo, radiation. We're not going to go to the hospital anymore. We're not going to have dialysis, IV fluids, IV antibiotics, therapies, transplants, anything like that. We're going to focus on their comfort, their goals, keeping them comfortable, and taking care of them at home. We kind of become their emergent care. Think of it as if you have cancer, you have heart failure, you go to a doctor, like a cancer doctor, you go to a heart specialist, right? We become the specialists that take care of this stage. Patients have to also understand that they have to elect the Medicare hospice benefit. So they have to sign a paper saying they want these services. If they aren't able to sign that paperwork, they have to have somebody designated to do so for them. Diagnosis for a patient to come on hospice. There are several. They used to be pretty cut and dry that only certain diagnoses qualified people for hospice. And nowadays, we're not looking at diagnosis anymore, we're looking at the prognosis of a patient. So what is truly going on with that patient? Heart failure, kidney disease, lung disease, cancer, dementia, Parkinson's, failure to thrive. We have to look at the whole patient and all of their diagnosis and why do they qualify. What are some things that might qualify a patient? What are things that we see every day that might say, well, that patient might qualify for hospice? What do you guys kind of see out there?
Significant weight loss.
Significant weight loss? Any others?
Pain.
Pain, yeah. Uncontrolled pain. Anything else?
A lot of sleeping.
A lot of sleeping. They're kind of withdrawing. They're not going to activities anymore. They're staying in bed. What about those patients that maybe were walking before and now they're wheelchair bound? They're falling a lot. They're getting weaker. What if they're just not eating a lot? They're having diet changes, right? Having swallowing issues. What if they're having a lot of infections? A lot of UTIs, a lot of upper respiratory infections. They're aspirating. Maybe they're going to the ER a lot. They're getting hospitalized a lot. You see them coming in and out of the facility. You might see that they're needing more oxygen. They're using it a lot more frequently. You might also see your patients starting to make comments that they're ready to be in heaven with Susie, their wife, that passed away 6, 7, 10 years ago. They're going to start talking about how they're ready to move on and they don't want to go to the hospital anymore. Those are kind of the patients when you start seeing it all kind of folding together that we should be looking at is what are their goals? Where do they see their disease process at this time? And maybe we should start talking to them about what they want versus just constantly sending them to the hospital when something goes wrong. They're speaking on, they're trying to have those conversations. So as frontline caregivers, when we're seeing that, if you feel somebody qualifies, we want to go to our social workers, our directors of nursing, and just talk to them about, has anybody talked about hospice? And then they can have the conversations with the families and patients. Hospice services are available 24 hours a day, 7 days a week. So if you need something in the middle of the night, if the patient needs something, if it's a weekend, a holiday, it doesn't matter. We're a phone call away. And we need to come if something is needed. Services. Hospice has to provide any medications related to why a patient's on services, and any medications related to their comfort. So nausea, vomiting, constipation, that makes them feel icky. We have to provide those medications. We also have to provide any equipment that a patient might need. Oxygen, wheelchair, walker, air mattress, anything like that. We have to provide that equipment for them so they don't have to rent it or buy it. If a patient is in your facility private pay, then we need to also provide them briefs, wipes, lotions, things like that. That's all part of their Medicare hospice benefit. Some of the direct disciplines, services that we provide. Each patient is given a nurse. You guys have seen the hospice nurse out here, right? Their role is to really be that, what do you want to say, key provider for hospice. They are managing their pain, they're doing an assessment, they're looking over medications, they're the person communicating with the patient, the family, the facility, the doctor. They're really your go-to person that's really in charge of that person's care. You guys have seen the CNAs come out here. The CNA is to do, personal cares, just like a lot of you do, bathing, toileting, changing their clothes, doing their hair, painting fingernails, doing some of those little extra things. We cannot duplicate anything that you guys provide. So if you guys are already doing a bath once a week, we can't come in and take over that bath. We can only provide an extra bath on top of what you guys already do, okay? Social workers and chaplains, they're here to do, or to help the family and patient with the coping of the disease process, help them with outside resources if they need it for bills, They're here to provide grief support, help with funeral arrangements, just lots of different avenues there. We have volunteers that can come and be with patients and read to them, play music, watch TV, just anything for companionship. And then we have our bereavement coordinators. And when a patient passes away, we don't just walk away from the family. We stay with them for 13 months after the passing. And we are providing them support during that time of loss. We are helping them through that grieving process through mailings and phone calls, with grief supports, groups. We have different events throughout the year. Sometimes we meet them one-on-one for coffee just to talk and listen. The nice thing about the bereavement program too is it's not just for families, it's for all of you guys. A lot of people don't know that. You guys are here taking care of your patients every day, right? You get very close to them, they become family. And you guys go through a lot of different stages of grief and loss when you lose a patient. And sometimes that can be overwhelming, especially when you lose 3 or 4 or 5 people in a row. So just know that we're here for you as well. If you ever just need somebody to talk to, or maybe you're feeling a certain way and you're like, I don't know if this is normal, I shouldn't be feeling this way. You know, this is my job, why do I feel that way? It can be confusing. So just know a phone call to us and we'll meet you for coffee. We'll sit down and talk. We're here for you. Let's say it has nothing to do with work and you have a traumatic loss in your family, or an event happens. I don't know if any of you heard about the event that happened in Alcester, a couple of years ago, where the lady ran into the nursing home. Okay, we went down there and we provided a lot of support to that staff and families. It's a big event, it's a lot of tragedy. We're here for that facility, okay? Hospice itself tends to be kind of negative, right? You hear hospice and everybody's like, oh, hospice, and they turn and walk away. I guess my biggest quest is get people to understand that hospice isn't negative. It's a very positive thing. People get pregnant, right? They plan for a baby, right? It's happy, it's joyful. You get your baby room set up and you have your decorations and you're picking out names. It's a happy, joyful event you plan for, right? Sometimes months before. A death should be just like that. People should be allowed to plan how they want to die. They should have the option to decide how they want to die. Do they want to die with pain medications? Do they not? What do they want their funeral to look like? You know, do they want to be at home? Or do they want to be in a hospital? Do they want their family with them or do they not? Hospice is most effective when we are there at that 6-month mark versus calling us in when they're already at the end of life and only have hours or days to live. We don't get to know the family. We don't get to support the family, prepare them for an end of life. We don't get to know the patient. And were they a school teacher? Were they a librarian? Were they a veteran? Can we honor them? You know, we have Making Moments Matter. We like to take people fishing and bake pies, and you know, we've taken people to the SDSU to the football games, and those are the things that matter with hospice. It's not about dying. That's just part of it. It's about living and how they want to live and how do they want to die. Okay? So I encourage you to have conversations with your patients. It's a scary topic, and a lot of times they do want to talk about it. It's just they're afraid nobody else wants to talk about it. They're afraid their kids don't want to talk about it. They don't want to hurt their kids. They don't want to scare them. And they're afraid we don't want to talk about it, so they won't bring it up. So when you see those cues, you see things happening, bring it up, talk to them. The most they're going to tell you is they're not ready, and that's okay. It's important. Do you guys have any questions about hospice? Things you see? Things you've wondered? Yeah.
Why is it that you said that you guys deal with a family 13 months after? If the family requests not to, why do you guys still insist?
We actually don't. if a family would, so we automatically see them for 13 months. We have a lot of families actually that contact us and say that they don't want the bereavement services. And at that time, we do take them off all our calls and mailing lists. Yeah. And if somebody you know doesn't want to be on it, please let us know if they got missed. Yeah.
At the end of life, I guess, what is one thing, like a person is actively dying, maybe hours or half an hour away from death, what would you say is a good thing for our staff? And how can we support the families of that resident who's passing away in those moments?
Good question. Really close at end of life, the most important thing for you guys to do is just make sure we're taking care of that patient. Repositioning is a big thing. Making sure they're comfortable, making sure that you don't have to have the blinds closed and don't have to have the lights off unless that's what they want. But it's okay to have the windows open. It's okay to have the door open. It's okay to go in. Don't avoid them. A lot of people have this misconception that, oh, the family's in there, we should leave them alone. No, don't leave them alone. They want you to come in. They want to know that you care. They want to know that you want to check on their loved one. You're not intruding. Don't be scared. It's okay to say, we just would like to turn her and check her and make sure she's okay. That gives them the opportunity to take a break. Sometimes they need a break. They've been sitting there for 3 days. They're exhausted. That's your opportunity to say, we're going to come in here, we're going to, reposition her. Why don't you guys go for a little walk, get some coffee, go to the bathroom. It's okay. Give them an opportunity. Sometimes they need that it's okay to step out because they feel guilty. Pain medication, the morphine and Ativan. A lot of places I hear they don't give them morphine. If I give them morphine, they're going to die. That's not true. The morphine is for their comfort. We don't give a big enough dose for them to overdose. We don't give them a big enough dose to kill them. It's enough to keep them comfortable. If you see a patient that's breathing really rapidly, struggling to breathe, their pulse rate's up, their chest is going, that patient's struggling. And if they're struggling, they can't move along in the process. They can't pass away. Their body won't allow them to. Or if they're going to, it's going to be a really horrible death. So we want to keep them comfortable so the body can naturally pass on in a peaceful way, okay? That morphine allows that. It helps them to be comfortable, helps them to relax. It opens up the airways so they can breathe easily. Morphine's a really good medication at this stage in life. Good oral care, using mouth swabs. Don't ever lay them flat. Always side to side, put their head up. Chapstick. I hate chapstick, or chapped lips. I'm a big person on that. Lotion the skin. That's a big thing. How many of us like little back rubs and hand massages? Things like that, okay? Any other questions? Anybody wonder anything ever? About the process, what happens? Yeah.
Did you ever talk about where they are going after death, or?
The patient?
Yeah, from a Christian perspective, or?
Some patients do. They've told us they see the light or that somebody's waiting for them. We've had patients that days before they see people that have passed on prior. That's normal. I think everybody has their own belief, and it's okay. We just meet them wherever they're at. As long as they have that belief, that's okay. Yeah. Any other questions? Okay. Yeah.
I just have a quick statement. 6 years ago, my mom passed away in a service. I don't know if it was you guys or another service like you, but it was actually phenomenal for us, the family, and for my mom. Thank you for everything you do.
Thank you. Thank you for what you guys do. It's not easy either. Thank you.
I actually have a comment about that too. My grandfather just passed away 3 weeks ago, and he was on Sanford Hospice, and it was wonderful, the care that everyone gave. So you guys really do make a big difference.
Thank you. I'm sorry for loss.
Thank you.
Yeah. Thank you for sharing. All right, anybody else? All right, we'll play a little game. I need an assistant because mine left the room. Who wants to be my assistant? Anybody? You just gotta hold a bag.
Sure.
It's not hard.
Okay.
All right. I got questions here. If you answer it, you get a prize. So, first question. When is hospice available to your facility or a patient? Only when needed, Monday through Friday, 5 to 8, or 24 hours a day, 7 days a week? Well, you can't all yell it out at one person.
First hand up.
He gets to pick. All right, next
Okay.
one. A doctor's order is not needed to start hospice services. True or false? What is one benefit of having hospice services for a patient or loved one?
Free.
Whoever said free is a good one. Anybody else have one? How long does hospice follow a family member after a loved one has passed? Right in front of you. She had her hand up first.
13 months.
Yep. Medicare, Medicaid, and some private insurances pay what percentage of hospice? 100%. Gotta get somebody over here. They're hogging on the candy over there. All hospice patients all hospice patients only have days or hours to live. True or false? False. Great shirt. I saw her arm first. How many candy bars do I have left?
3. 3 more good questions.
Name 3 declines you might see in a patient who would qualify for hospice.
Weight loss, not doing grand activities, sleeping more.
There you go. Name 2 disciplines or people who might come out and visit a hospice patient. There you go. Right here. She said therapist or social worker.
What is it?
Carol.
Oh, hi.
Is that it?
There's one more.
And that one's for you for being my assistant.